Hi, this is Rick Wiggins. I'm one of the radiologists here at the University of Utah. I'm a neuroradiologist, and my interest is in head and neck imaging. So we're going to talk this afternoon for the next 2 hours about head and neck imaging issues. We're going to talk first about emergency head and neck imaging, and then we'll talk about central skull base. And these are two good areas to really highlight the differences in the power of the big techniques that we talked about before with cross-sectional imaging and how we use CT and MRI to look at these areas. Specifically in the head and neck world, we have all these parts that are very different. So how we think about the central skull base and the cranial nerves and the extracranial head and neck and the orbit and the paranasal sinuses and the temporal bone for head and neck imaging, there are all these very different places. So we're going to talk about the similarities and differences in these next two lectures as we look at emergency head and neck imaging, and then in the next hour we'll look at central skull base. These are both great examples of the power of CT and MRI and how we use these imagings and how it helps us image our complicated patients in the extracranial head and neck. So we're going to start off first talking about emergency head and neck imaging. So we'll talk about infectious and inflammatory processes and all these different areas, and we'll see how different they look. Skull base infection and inflammatory is very different than dental disease, is very different than orbit, is very different than sinonasal, is very different than the extracranial head and neck. So we have very varied and different anatomy in all these areas. So again, CT and MRI is what we're predominantly using, and cross-sectional imaging in this world. So we'll talk about these modalities and how we use them in the head and neck. And specifically, when we're thinking about infectious and inflammatory processes, we try to figure out the source of something. We try to figure out, is it something that looks like it's treatable? And we look for the surrounding complications. And as you'll see when we go through these next couple of lectures, in the head and neck imaging world, it's very important to not only talk about the primary pathology, but we talk a lot about how the tissues around it are reacting to that. That's very important in these pathologies and how we think about them. So we'll look at a whole bunch of sources of head and neck imaging, and we'll look specifically at CT and MRI and how we use these modalities to help us differentiate these areas. And again, to think about those big important things. Is there something that's treatable? What is the source of the infection or inflammatory changes? And are there any adjacent complications? Those are kind of the three big things that we always think about with these cases. Now, sometimes we can think about it kind of being an emergency for the imager or the radiologist. Sometimes we pull up a case and it just looks, crazy. There's all these things everywhere. And one of the things that we talk about with cervical soft tissues, this is a pediatric case. You see the spine looks very small compared to the rest of the neck here. In this case, in all these areas, we have this big multi-septated mass with infectious inflammatory changes kind of around it. The image on the left there is your axial T1 post-contrasted, and over on the right of your screen is the T2 FSC with fat saturation. So you see this lesion that looks like it's taking over almost the entire whole neck. And there are some congenital pathologies. This is a venous lymphatic malformation. Sometimes it's mostly venous elements. We sometimes talk about that as a hemangioma. And sometimes it's mostly lymphatic elements. We might call that a cystic hygroma. So we have this huge spectrum of things that we might call venous lymphatic malformation, a big spectrum in between these. But these are transspatial masses that can get infected, like we see in this case, where we see these inflammatory septations. You see those bright white areas on the post-contrasted image where the septations are inflammatory and infectious changes around this. So we have a couple of big areas in the head and neck world that we talk about. We'll start off first talking about the airway. And we have some big anatomic subunits that we talk about that are especially important with cancer, the upper digestive tract. We talk, for example, about the nasal vault and the nasopharynx and the oral cavity and the oropharynx, how these areas are similar and different to each other. But the upper air digestive tract and the airway is a big important thing, obviously. And one of the things that we're always trying to differentiate is something like normal adenoidal tissue. So this is a case where we have an axial post-contrasted T1 MRI study. And we see the fat is dark, like the subcutaneous tissues around the cheek. And you see the arrow here is pointing towards this adenoidal tissue. There's nasopharyngeal adenoidal tissue, sometimes called the adenoids. that are up high, and you can see these inflammatory septations within it, these white lines on this post-contrasted image. And that helps me guess that this is just inflammatory changes to that adenoidal tissue, what's called part of Waldeyer's ring, the ring of adenoidal tissue that's around the upper digestive tract. So we have the base of tongue, lingual adenoidal tissue, we have the palatine tonsils on both sides, and we have the nasopharyngeal tissues up high. So that makes a ring of adenoidal tissue around the upper digestive tract, with the base of tongue, the palatine tonsils, and the nasopharynx up high. That's called Waldeyer's ring often. And we're often trying to differentiate, is this just prominence of that adenoidal tissue, or is there actually an abscess or a mass in that location? And I was told by several people a long time ago that if you were over 40 or 50 and you had prominent adenoidal tissue like this, you either had lymphoma or nasopharyngeal carcinoma. And we know now that that's not true, and we can do better imaging with our cross-sectional imaging. And when we see these inflammatory septations, these white lines in that adenoidal tissue, that helps me guess that this is just a prominent adenoidal tissue at that level. And we can apply the same thing to the palatine or fascial tonsils. So here we see the palatine tonsils on both sides are a little prominent. This is an axial post-contrasted CT. So this is a CT scanner. So we're looking at densities of stuff. Remember that CT scanner is just a big, stupid densometer. We're looking at densities of stuff. Bone is dense, it's very white. Air is not dense, it's black. Everything else is in between. So anytime we start off looking at a soft tissue neck CT, we want to think about a window level setting, something like 440, so that air is different than fat. That's very important in these cases that we think about. So here, similarly in that case, we can see these white lines kind of going through that palatine tonsil, and that helps me guess that this is just prominent adenoidal tissue at that level, that there isn't actually an abscess in this palatine tonsil on the side. So on both sides of the airway, we have these palatine tonsils, and we see the inflammatory septations on this case. That tells me that this is just prominent adenoidal tissue. Now we want to differentiate that from an intertonsillar abscess or a peritonsillar abscess. And we think about the peritonsillar abscess is the most common head and neck infection that we can get in the head and neck. On cross-sectional imaging, though, we sometimes talk about these very differently. So here in this case, we see a fluid collection with surrounding enhancement. So that's a good appearance, really, for an intertonsillar abscess. So here's one of the tricks. Depending on your specialty and what you end up going into, sometimes the people looking at the cross-sectional imaging study have different words to describe things than the pathologist and the head and neck surgeons. So for us on cross-sectional imaging, if there's just a fluid collection in the palatine tonsil, we just call that an intratonsillar abscess. It looks like a fluid collection with surrounding enhancement. Anywhere in the body, that's an abscess. So here, it's within the tonsil, so we call that an intertonsillar abscess. Now, if you say that to a head and neck surgeon or pathologist who does head and neck, they'll say there's no such thing as an intertonsillar abscess. It's always a peritonsillar abscess because the actual abscess is around the inflammatory infectious tissue. It's not actually within it. So in this case, axial post-contrasted CT, it looks like we have fluid collections on both sides with surrounding enhancement. So it looks like bilateral intratonsillar abscesses. Now for us on cross-sectional imaging in the head and neck radiology world, if that fluid leaks out from the tonsil into the surrounding spaces, like we see in this case, we call that a peritonsillar abscess on imaging. And again, to the head and neck surgeons and the pathologists, it's always a peritonsillar abscess. They say there's no such thing as an intertonsillar abscess. So just remember that we sometimes use different words for things on cross-sectional imaging than other people do on pathology or in clinical exam. So this is an axial post-contrasted CT. We see a fluid collection that's centered in that palatine tonsil, and we see surrounding inflammatory infectious changes, and we see the fluid has leaked out of the tonsil into those surrounding spaces. So that's a good appearance for a peritonsillar abscess, or PTA, and that's the most common infection thought of the head and neck area. So we have a spectrum. So here's kind of a montage of that spectrum. So over on the left, we have tonsillitis. So here we see those inflammatory septations within the palatine tonsils on both sides. In the middle, we have an intertonsillar abscess. This is a fluid collection that's still confined to the tonsil with surrounding inflammatory infectious changes. And over on the right, we have a PTA, a peritonsillar abscess. Here we have fluid that's leaking out into the surrounding spaces. So we call that a PTA, a peritonsillar abscess. And again, that PTA is thought of as the most common head and neck infection on presentation of patients. Now, this is one of the few areas where plain film is actually used in the head and neck work. Plain film is amazingly bad for trauma if you're trying to see fractures or to evaluate sinus disease, but in children especially, as well as adults, when we're sometimes evaluating the upper digestive tract, this is one of the few areas where plain film is still used and thought of as effective in the head and neck world. So this is a lateral view of the neck. And we can see the mandible. Looks like the patient's edentulous. We don't see any teeth. We see the hyoid bone here kind of in the middle. And we see the arrow is pointing to this real thickening of the aryepiglottic folds. So there are folds that go from the arytenoid up to the epiglottis. So those are the aryepiglottic folds. And on this plain film, they're very thickened on that level. So we see the epiglottis extending up, and those aryepiglottic folds are very thick. And that's what we sometimes call adult supraglottitis. Same thing in a kid, we would call epiglottitis, but an adult, just by naming convention, we often say supraglottitis. Now, on otoscopic view, if you scope that patient, you can see the cords, and they always scope it and kind of look at it upside down to what we think about as imaging. So we always think about turning that image around so that we can see the vocal cords in the correct way. So now we see the anterior commissure, that's anterior, and the posterior commissure posteriorly. We're looking at these thick aryepiglottic folds kind of in the back, and you see what looks kind of like a Candida infection, all this white stuff that's over the vocal cords and the true cords and the false cords. That's laryngitis. So that's what it looks like on endoscopic examination, looking down at the larynx with all the swelling, some redness of the airway, some edematous changes, and that overlying infection. So that's what kind of laryngitis or supraglottitis looks like on endoscopic exam. Now, if that's diffuse and more edematous, you see here all the thickened changes to the aryepiglottic folds. You see the false cords, the true cords, and you see all this white plaque like an overlying Candida infection of a chronic laryngitis, where we have more edematous changes and thick, boggy changes to all of those structures. So on cross-sectional imaging in that same patient, a case like that, these are axial post-contrasted CT, so I can see the jugular and I see the carotid. I see all the contrast in those blood vessels. And here I see those arrows pointing to these edematous changes. So these wet, boggy changes that we see with adult supraglottitis is thickening of those aryepiglottic folds on both sides. So you can see how thick those aryepiglottic folds are, and you can see kind of inflammatory stranding in the fat, dirty fat, gray fat, creeping fat, whatever words you like to use. You see the very dark fat of the subcutaneous tissues on the outside of the neck looks very different to the fat that's there at midline on the image on the right with the arrow, where we see the fat that should be behind the hyoid that should be very dark, just like the subcutaneous fat. So here there's a lot of inflammatory infectious changes that are around that area. Here's another case. So again, these are axial post-contrasted CT images. I can see contrast in the jug and the carotid on both sides. And I can see all these wet, boggy changes here behind the airway. So that's what we see with adult supraglottitis. So I can look at the imaging. I think about what the modality is. This is a CT scanner, so it's just a big, stupid densometer. I'm looking at densities of stuff. And I can see that the density of the stuff is low. It's more like fluid, closer to fat than it is to muscle. We see the submandibular glands on both sides, and we see the SCM, the sternocleidomastoid muscles on both sides. So we have these internal standards, things we can compare what we think is pathology to decide what the density is. Is the density high? Is the density low? And what is the density similar to on the rest of the imaging study? So this is a patient who had adult supraglottitis, where we have wet, boggy changes to the upper digestive tract, and we can see kind of the low density edematous changes along the upper digestive mucosal surfaces consistent with supraglottitis. Now here's a sagittal reconstruction. So again, as we talked about that first day, we can take an axial data set and we can reconstruct it in a lot of different ways. So here we've done a sagittal reconstruction. We see the spine, the vertebral bodies on the back. We see the spinal cord. And instead of a thin aryepiglottic fold at this arrow, we can see a thick, boggy aryepiglottic fold sticking up. So that should be just a thin fold. The larynx is kind of unique in terms of head and neck anatomy because we have this cartilaginous framework and the mucosal surfaces are draped over that framework that make all these folds and air-filled spaces that we discuss as anatomic subunits. So we should have a thin fold, a thin line of the aryepiglottic fold here, and here we see kind of a thumbprint. It's a big, boggy appearance at that level. So it's a good appearance for adult supraglottitis, infection of the supraglottic larynx in an adult. Now, in a child, we think about this differently. So here's a normal on the left of your screen and pediatric epiglottitis on the right. So again, we can think about this normal anatomy. So we see the tongue anteriorly. There's a base of tongue lingual adenoidal tissue. Here we see the hyoid and cross section on the sagittal graphic. We see the thin epiglottis, and here's the aryepiglottic fold that's going down from the epiglottis. And here on the right image on this graphic, you can see an example of pediatric epiglottitis, where we have all these inflammatory and infectious changes of the epiglottis at that level. So it's red, it's boggy, you see the increased vascularity of that site. And as you can imagine, if this were to progress and keep getting more edematous, after a while we may block off the airway. That's going to become an emergency in this case. And again, another area where we sometimes use plain film. So here's a lateral x-ray, a view of a pediatric case. You see the face looks very big compared to the rest of the body. And we see the soft tissues in front of the vertebral bodies are way too prominent. And again, similar to that other image, we see the arrow here pointing at the aryepiglottic fold, which is very thick and boggy. So kind of subtle change, but that's a good appearance for pediatric epiglottitis, where we sometimes use plain film in the head and neck world. Usually we're always talking about CT and MRI. Ultrasound is great for its portable technique as long as you're familiar with evaluating the echogenicity of different structures. But this is one of the few places where we sometimes use plain film. Now here's a gross specimen. So if we're showing you a gross specimen, you know that was a bad outcome. And we see here all these thick, boggy changes of the epiglottis at that level. So we see the aryepiglottic folds again here and back, and we see it's very red and very edematous, thick, boggy changes. If you could imagine this was an endoscopic exam and we were looking at these structures, that's a good appearance clinically for the pediatric epiglottitis, where we have all those inflammatory infectious changes. So just to compare, here's a normal endoscopic view on the left side of your screen, where we see the white true vocal cords. Above that is going to be the false vocal cords. And in the back, you have the two aryepiglottic folds on both sides. Now, when we're thinking about croup, that is a subcricoid stenosis. So that's below the larynx. So on the right image, we see the very white vocal cords with the small anterior commissure in the front, but below the true vocal cords, we have narrowing of the airway. So that is a patient with a subcricoid stenosis from edematous changes, and that is what we see with croup. So little children who wake up in the middle of the night with kind of a barking cough turning blue, and we try to get them to calm down and relax and breathe, take them outside if it's cold, put their head in a freezer to try to have the cold air decrease the edematous changes. That's what we see with croup in these cases on endoscopic examination. So with imaging, again, this is another one of the few areas where plain film is used in the head and neck world. This is an anterior view. So on the left side of your screen, you have a normal airway. And on the right side, we have croup. So on the normal image, on the anterior view, you see the airway very dark. And at the very top, you have a normal shouldering of the airway when you get up to where the cricoid is. And on the right side image, we see what's called steepling. So you have these edematous changes in the subglottic airway, so below the cricoid, subcricoid or subglottic narrowing of croup below the cricoid in those laryngeal cartilages. That's what we see with plain film, is that steepling instead of the shouldering that we see up higher on the normal anterior view. So here's an example, again, of supraglottitis. This is an axial post-contrasted CT. Again, a similar thing. In an adult, we often say supraglottitis. In a child, we say epiglottitis. But on CT here, it looks like we have a fluid collection on this arrow on the left image, and we see thick, boggy changes around the epiglottis. And we can see this is a post-contrasted CT. We see contrast in the carotid and the jug. And on the sagittal reconstruction on the right image, you can see that arrow, again, pointing at a thick, boggy epiglottis. It's not thin like we expect to see with the suprahyoid, the part of the epiglottis that's above the hyoid at that level. Now here's another case. So this is an MRI scan. So we look at the MR, and one of the things that's very helpful with MR studies, if you have the nose, you can look at the nose to see if it's before or after contrast. If the CSF is dark, that's a T1 image. So here we look at the CSF, the cerebrospinal fluid around the spinal cord. It's dark, so I'm guessing this is a T1 image. And I look over here at this image on the right, and it's bright. So this is a T2 weighted MRI image. And I have a fluid collection that these arrows are pointing at that's between the airway and the vertebral bodies. So we have these spaces we sometimes refer to, and sometimes people use very generic words like retropharyngeal. It's behind the pharynx, and prevertebral. It's in front of the vertebral bodies. So depending on which words we use, we try to think about things that are in front of the prevertebral musculature as retropharyngeal. And if there's a pathology in that prevertebral musculature, the muscles that are right in front of the vertebral body, we call that prevertebral. So this is an axial T1 image on the left, and we have an axial T2 image on the right because the CSF is bright, and we have this big mass that's there at that location. Now we often see retropharyngeal abscesses if we have fluid collections here with surrounding enhancement, but we look at this image here, and it looks like it's bright on the T1 on the outside. Now you always need to be careful wherever you end up. Are the images fat saturated or not fat saturated before or after contrast? That can get confusing. This looks like a fluid collection with surrounding enhancement. So you want to check very closely to be sure if this is a T1 weighted image before contrast or if it's a T1 weighted image after contrast. That's going to make a big difference here. If this is before contrast, this could actually be just a hematoma. And this turned out to be a spontaneous retropharyngeal hematoma in this case at that site. So we have a mass at this location. It's in front of the vertebral body. It's behind the airway, the pharynx. And we try to look at that musculature and see if it's involving that musculature or if it's in front of it to differentiate retropharyngeal from prevertebral. But that's kind of a tricky concept in these tricky spaces that are in these areas. So some people use those words kind of generically as anything in that area. In this case, turned out to be a spontaneous retropharyngeal hematoma from a patient whose INR was way out. They just had leaky blood vessels. Now we can also get pediatric cases that may have infected cysts in some places. So here we have an axial and a coronal post-contrasted CT. So it's a CT image. It's kind of a standard algorithm. We're looking at the soft tissues. And we see the arrow on the axial images is pointing at the left lobe of the thyroid. So on the right side, we see where the thyroid is, where the carotid is, where the internal jugular vein is, and where the sternocleidomastoid muscle is. And on the left, we have a lot of inflammatory infectious changes around the left lobe of the thyroid. And here in the coronal, you can see the arrow pointing at kind of a fluid collection extending up from that left lobe of the thyroid. So with branchial cleft abnormalities, if you remember that, we think about the arches that they may arise from, 1, 2, 3, 4, 5, 6. 5 is supposed to completely regress. It's very boring. We never talk about it. 95% of the branchial cleft abnormalities are supposed to be branchial cleft cysts, but we can get cysts, we can get sinuses, and we can get fistulas, depending on if we have a fluid collection with a tract that may go to the skin and or to the upper air digestive tract. Anytime we have inflammatory infectious changes, though, in the left lobe of the thyroid, we think about the infected fourth branchial cleft cyst, and the coronal and the sagittal sometimes are very nice to show that fluid collection going up or down. Here's another case. So now we have an MRI. So this is an axial T1 MRI on the left side of the screen and an axial T2. If I look at the CSF, I see how the CSF is bright on this image that's on your right screen. And if I look at the T1, I see that CSF is dark on that side. So I know that's a T1 weighted image. And I'm going to try to figure out, is this before contrast or after? If I can't tell from all the text kind of that's in the corner of that image, I'm going to try to differentiate that. But I can see where at the level of the airway, we see the airway in the middle. Here's the cricoid back posterior to that. We see the laryngeal cartilage. Here's the carotid flow void. This is the common carotid, that dark circle on the T1. And immediately lateral to that, we have a mass. Now on the T2, we see the same thing. Here is the airway. We see the cricoid bone in the back. we see the common carotid artery flow void, and it looks like we have a flow void of the internal jugular vein. But it looks like it's all opacified on the T1. So this is a good appearance for jugular vein thrombosis, and there's a lot of infectious inflammatory changes around it, so we would call that jugular thrombophlebitis. There's infection in that case. So just an example of how we might use MRI. You see on the T2 all this bright signal that is around the internal jugular vein that's thrombosed. These are all infectious inflammatory changes. So in somebody, for example, who has a long-standing central venous line in place in his jugular vein, this is something that we might see developing with thrombosis of the internal jugular vein over time, may turn into thrombophlebitis. So here's another case, very similar. So this is an axial CT on the left side of your screen image, and it's after contrast. I can see contrast in the carotid and the jug, and the coronal reconstruction is the right side image. So on the left side, we can see the arrow is pointing to that thrombosed internal jugular vein. So on the contralateral side, on the other side, we see the normal sternocleidomastoid muscle, we see the internal jugular vein, then we see the common carotid artery, then we see the thyroid. Here we see the trachea airway, so we're below the cricoid, and here we see the esophagus posterior to that. So here's the right lobe of the thyroid, then the right common carotid artery, and then here's the jugular vein. And we see the density in this jugular vein is not full of contrast like we see on the contralateral side. So this right internal jugular vein is thrombosed. And on the coronal reconstruction, we can see opacification of that internal jugular vein consistent with thrombosis. And then we look at the stuff around it. Look at the fat on the contralateral side. If you look at the fat on the left side, posterior to and next to the internal jugular vein, it's all very dark. So that's more normal looking fat. But if we look at the fat that's around the internal jugular vein on the right, where the arrow is on your left-sided image, we see all these inflammatory infectious changes around there. So this is, again, why it's important when we start looking at a cervical soft tissue CT, we want to window it so that air and fat are different on the images. We talk about window level settings sometimes when we look at these studies. So this is going to be a window level setting, something like 440, so we can differentiate what's fat and what's air. That's very important. And here we see all these inflammatory infectious changes in the fat around the jug consistent with thrombophlebitis. Here's another case. So here's a CT. So we're looking at densities, and here's kind of a standard algorithm on the left side of your screen and a bone window on the right side of your screen. We see all the vertebral bodies, and we see the arrow pointing to this calcification that is below the anterior arch of C1. So we have the tip of the clivus on the very top of your image, the triangular shape of the skull base. Below that, we see the dens going down and connecting to the body of C2. But in front of the dens, we have the anterior arch of C1. But immediately below that, we have an extra calcification. And this is something we sometimes see with longus coli tendinitis or hydroxyapatite deposition disease. Patients may have neck pain, gets better with aspirin. And we have this little calcification that may cause kind of inflammatory changes of the prevertebral soft tissues, and we see a little bit of thickening of the soft tissues in front of the vertebral bodies. If you like numbers, some people use 22 at 6 and 6 at 2, 6 millimeters for how thick the soft tissue should be in front. If you don't like numbers as an internal standard, you can use the vertebral body. If you look at how big it is front to back, it should be half a vertebral body above the hypopharyngeal shelf down here, and 1.5 vertebral bodies below the hypopharyngeal cell. So the soft tissues here in front of the vertebral bodies are too thick, and if these inflammatory changes are within those muscles in front of the vertebral body, we talk about that as prevertebral edema. So here's a case of longus coli tendinitis with that prevertebral edema. Here's another case. Here's a lateral X-ray, and we see the vertebral bodies and the spine. We see a lot of degenerative changes, and the prevertebral soft tissues are way too thick. And we see the nasogastric tube and the endotracheal tube here going down. So we know where the airway actually is, and there's just way too much soft tissue in front of the vertebral bodies at that level. And we do a CT. So here's an axial CT image, and we can see the endotracheal tube and the nasogastric tube in the airway pushed way anteriorly. We can see the vertebral bodies, and here we see all this contrast leaking up. And this was a very rare case of somebody who was in a bad car accident, and I went to check the CT scanner, and I saw all this contrast at this area, and they rushed in to check the patient, and he had actually had an aortic rupture that extended up superiorly, dissecting along these spaces. So this is actually the prevertebral space. This is the prevertebral space, and this is the retropharyngeal space with this fascial layer that's in between them with all this contrast in front of the vertebral bodies. A very rare CT of an active aortic rupture ascending. And so this high density here we see is actually contrast from his aorta that was dissecting up in his neck on that study. So those are some emergencies that we see around the airway. So next we have the sinuses. Now, frequently we don't get that excited about sinus disease itself. People often blow off sinus disease in these cases. The problem is with patients who have sinus disease, we give them their meds and they stop taking them before they're all done. So the doctor writes the script. He says, keep taking the meds till they're all gone, but the patient feels better after a couple of days and they stop taking them. They may go see another doctor. They may go back to the same guy. He gives them a different antibiotic. That happens over and over again. And after a while, the infection may extend from the ethmoids into the postseptal soft tissues, the soft tissues that are behind the orbit, like we see in this axial CT after contrast. We see a fluid collection with enhancement around the outside that's adjacent to the medial wall of the orbit that's consistent with a postseptal abscess at that location. And here on the coronal reconstruction, the right side image, you see the arrow pointing to this fluid density with surrounding enhancement. You see how it's pushing that medial rectus muscle laterally towards the optic nerve. So this is an example of sinus disease that went laterally into the orbit on that case. Now, one of the things that we think about with sinuses is we're trying to look at the case and see and think about, is this somebody who may respond to sinus surgery? Is this somebody who needs FES, functional endoscopic sinus surgery? And in those cases, we think very much about, is there any one particular air cell that looks like it's completely opacified? And here on this coronal CT, we see that the maxillary sinus on the left is completely opacified. We have complete opacification of the ethmoids that the arrow is pointing to. And on the right-sided image, more anteriorly, we see that frontal sinus on the left is completely opacified. So the frontal, the anterior ethmoid, and the maxillary sinuses are all completely opacified. So that is consistent with an osteomeatal unit type of obstruction. And these can lead to a very debilitating five-finger pain and pressure pain in the patients. So anytime we see some sinus air cells that are completely opacified, we want to try to mention that, because if we don't open up the drainage, the sinus disease will try to find its own way to decompress, possibly into the orbit like we saw in that last case, or to go in another direction. What's sometimes called a Pott's puffy tumor, acute onset of a subperiosteal abscess. Here we have frontal sinus disease that goes anteriorly into the subcutaneous tissues. So here we have near complete opacification of the frontal sinuses. We've got two axial CT images. There's kind of a bone window on the left side of your screen and a standard algorithm on the right side. We see the subcutaneous air and all the inflammatory infectious changes that are around it, and we see destruction of the anterior wall of the frontal sinus. That's a good appearance for a subperiosteal abscess of acute onset, or Pott's puffy tumor, where we have a soft tissue mass that's arriving anteriorly from that soft tissue. So that sinus disease may decompress anteriorly into those frontal soft tissues, or it may go back posteriorly or down into the orbit. Here's another case, that I think that same case where we see air and all those inflammatory infectious changes of the forehead. So you can imagine this mass coming anteriorly on the forehead from the frontal sinus disease that's decompressing itself because it was not opened up. Here's another case. Here we had sinus disease that, again, was not opened up. And if it keeps going on long enough, here we ended up with an abscess not only behind the orbit, but you see up at the top of the image, we actually had an intracranial, essentially an epidural abscess from hematogenous spread going up intracranially from this poorly controlled sinus disease. So again, with untreated disease, here's an MRI case. So here's a coronal MR on the left side of your screen, and we can see complete opacification of the frontal sinuses. And on the right-sided image, this is a sagittal, and it's post-contrasted. We remember the nose. If you look at both of these images, the nose is bright. The nasal mucosa and the turbinates we see are very bright. So the nose. So this is a post-contrasted image. And here we see infection from the frontal sinus disease went both anteriorly into the subcutaneous tissues, but it also went posteriorly and led to an intracranial abscess. We have a fluid collection with surrounding enhancement. Anywhere in the body, that's an abscess. And here you see all the low intensity. So again, remember on MR, we talk about intensity, and on CT, we talk about density. We have a lot of low signal intensity in the frontal lobes of the brain, consistent with vasogenic edema. The brain is angry about this abscess at that location. And intraoperatively, that was a big, thick, gooey mess where we had to do the craniotomy. And we had all these infectious inflammatory changes that were drooping down in there. It's like nachos with really cheesy dip on it. Now, here's another case we looked at. So we did a CT on this patient, and he had what the resident thought was hyperostotic changes. So these are CT images, and these are bone windows. So we're looking at the bones, and we see the very high density and thickening of the bone anteriorly. But on the sagittal bone algorithm CT, you could see it looked like there was a little hole that was extending up superiorly from the frontal sinus. So we wanted to evaluate that better. So we had a CT where we're looking at the densities of stuff. It's very good for bones. But if we want to see intracranially, you see we may not see the brain as well here on the CT as we might with an MRI. So we decided to get an MRI on this patient because things that are very watery, like the brain, we see pretty well on MRI. So we did an MRI, and you see there's a very large mass at this level. And you can see on the sagittal T2, here the CSF on both of these images is bright. So these are T2 weighted MRI images. We have a very large mass that was extending essentially another epidural empyema from this frontal sinus disease. But the mass was actually so big and causing so much mass effect that we actually had a syrinx. You can see down low where the arrow is on the sagittal T2 weighted image on the right. So this was a very big epidural abscess that was leading to a syrinx. Epidural abscess at that level. And when they open that up with a craniotomy, it's just all flowing pus, a big waterfall of pus that was coming out in that case. Now, sinus disease can get very bad very quickly, especially from the sphenoid, because the sphenoid sinus disease, immediately lateral to that is the cavernous sinuses, where we have the internal carotid artery, and we have cranial nerve 6, and then the lateral wall of the cavernous sinus, we have cranial nerves 3, 4, V1, and V2 going down the wall. So this is a MRI study that was done. This was a diffusion image. So we do diffusion to look for ischemia, especially acute ischemia. And we see this little bright dot on the back of the diffusion image, the image on the left of your screen. And on the right, this is an axial T1 image. We look at the nose, and the nose is bright. So this is a post-contrasted image. And we look at the nasal mucosa, and we see that the sphenoid sinus is not enhancing on its mucosal surface like the other paranasal sinus disease. Like the other paranasal sinuses in this case. So all the other walls of the paranasal sinuses, especially the ethmoids we see here in this post-contrasted MR, are enhancing, but the walls inside that sphenoid on the left are not enhancing. So this turned out to be fungal disease at that site. So there was a little dot of posterior ischemia on this case. So they're thinking it's a vascular lesion, so they decided to work that up. So they went ahead and did a CTA. So on the CTA, it looked like there was a little aneurysm that was extending off. So they confirmed that with the 3D reconstruction. So we see the arrow pointing to that little aneurysm that's coming off the cavernous carotid. And they decided to confirm that with an angiogram. So they did a catheter angiogram. So this is a DSA, digital subtraction angiography image. It's an anterior view. And we see a little aneurysm the arrow is pointing to coming off the cavernous ICA. So they decided to go and do a big surgery on this to put a clip on. And the surgeon said that he got in there and got into towards the cavernous ICA. And as soon as he went and put the clip on, he said that the whole vessel was all just friable and the vessel just fell apart and it's just started filling up with blood at that level. So this is a very bad outcome on that case that we had, unfortunately, kind of badness in this case where the carotid just fell apart because of essentially sinus disease. This was fungal sinus disease that invaded the cavernous sinus and led to a fungal aneurysm. But because we didn't recognize the importance of the sphenoid sinus disease, that wasn't recognized on the preoperative imaging. Now, again, we look at the images and we try to figure out, does everything look like it's supposed to be, and what else on that imaging does it look like? And you can see here on the axial T1 before contrast that sphenoid sinus is very bright. And you look at the T2 and it's very dark. And that's what we may actually see with fungal disease on this imaging. So we have a lot of fancy imaging. We can do contrast, we can do MR spectroscopy, we can do MR perfusion, all these fancy techniques. But the plain old basic T1 and T2 actually give you a lot of information if you just pay attention to it. And when we gave contrast again, you saw that the inside of that sphenoid sinus was not enhancing like the other ones are. So anytime something looks different than the others, we're more suspicious of that. And that sinus was normally aerated on just a study done just a few months earlier on the CT. And around the central skull base and anywhere around those bones and the temporal bone and the anterior skull base, this is a big area where both CT and MRI are complementary. If we have both studies, we can frequently tell you exactly what the pathology is. Now, one of our sinuses center surgeons one day was doing an OR case, and he texted me help and sent me an image of what he was looking at. And pulled up the image, and the image was just kind of what he was looking at in the OR. I had no idea what it was he was looking at. Then his resident starts FaceTiming me, showing the image. I still have no idea what he's looking at. So I can't tell from the bottom of this hole exactly where he is. But I pulled up the patient's images, and we started to look at this and go through it. So here we have an axial T1. We see the nose is bright, so this is a post-contrasted image. And the arrow is pointing to something that's bright here. This is a great case that kind of highlights the importance of fat saturation and how important it is to pay attention to whether or not your imaging is with fat saturation or without fat saturation before and after contrast. They thought that this area was just normal fat up here near the optic strut superiorly, but it turns out it was actually enhancing. That's why you have to compare the before contrast to the after very closely all the time. So this is the axial CT that correlates with that. Again, so you see we're looking at densities on the CT and we're looking at intensity on the MRI. On the CT, we actually have fat density on one side, but the arrow is pointing to the side that's actually fluid at that level. It's not the same as the other side. And this is the before contrast. So you see how bright the optic strut is right next to the carotid on the contralateral side, but the arrow is pointing to the side that's actually dark before contrast. So it's very deceiving on that post-contrasted image because that was actually enhancing. It was not actually fat. This post-contrasted image is not fat saturated, so that could be confusing. When you look at the coronal, though, they did do fat saturation on the coronal, and there you can see that's actually bright, whereas the contralateral side is dark. So in this coronal post-contrasted image actually has fat saturation, you can see that it's fat at that location. Now that's bright. So that makes a huge difference to this patient if they had recognized that preoperatively. The CT, again, we're looking at densities. That can be a little confusing, but we have very important anatomy right here. This is a coronal CT. We're going through the sphenoid sinuses, so the airway is down below it, and you see the arrow is pointing to that optic strut. Immediately medial to that optic strut is the optic nerve canal. So the optic nerve is right there at that location, and immediately lateral to that is where the cavernous carotid is. So the internal carotid artery is right there at that location, and the optic nerve is immediately above it. So that's very important anatomy at this area. So disease from the sphenoid can get into the orbit or into the cavernous sinus because the wall there is very thin at that location. So next we have teeth. We radiologists mostly ignore teeth, but we do think about dental infection a lot. So here we have an axial post-contrasted CT images, and we can see a fluid collection that's right next to the mandible. We see it looks like on the second image on your right, it looks like the fluid collection is on both sides of the mandible. Anytime we see what looks like an abscess next to the mandible, we're going to be very suspicious of the teeth, and we're going to look very closely at the teeth because dental origin infection is a popular thing to happen there. So here in the coronal standard algorithm post-contrasted window, we see the low density, looks like fluid, looks like there's surrounding enhancement. It's bright on the outside, so that looks like an abscess. And when we look at the bone algorithm here in the sagittal, we see the bad tooth. So that is a dental origin abscess, a dental origin infection there in that case. Here's another case. This is more impressive. We have an axial post-contrasted image. So on the contralateral side on the right, we see the very dark fat. This is the parapharyngeal fat. It's fat next to the pharynx, so it's parapharyngeal fat. There should just be fat at that location, but it's very important because we see how it's displaced when we think about pathology here. So on this image, we see enlargement of all the muscles on the left side, and we see fluid with surrounding enhancement. Again, this looks like an abscess adjacent to the mandible, so we're going to think about teeth, and we're going to look at the teeth very closely. We find that parapharyngeal fat, and we see it's pushed medially and posteriorly, helping us guess that this lesion is arising from the masticator space. That's where the muscles of mastication are normally. We see the masseter here out laterally in the medial pterygoid, medial to the mandible. So on this side, we have an abscess adjacent to the mandible. So we want to look very closely at the teeth. And sure enough, this patient had an empty tooth socket from a tooth that was recently removed in that case. So next we have salivary glands. These usually aren't acute in terms of patient clinical presentation, but they're often totally misdiagnosed or missed on imaging or thought of as something much more exciting than they really are. We like symmetry in neuro. So things that are symmetric and things that are midline are often hardest for us. So here on this axial post-contrasted CT, I can see contrast in the carotid and the jug. So I know this is after contrast. I see a big parotid gland on the right, and I see a very small one on the left. We know that the parotid duct goes over the masseter and pierces the fascia over the second mandibular molar. And we know that infection, because our mouths are so dirty, can go from our mouth back into the parotid and cause a parotitis or parotiditis, infection of the parotid. Early a parotitis, the parotid can get enlarged and weird enhancement, and later over time it may kind of shrink down in size. So here's another case. So we see the submandibular glands on both sides, and on the standard algorithm image, we see this focal calcification within the submandibular gland, and we see that very nicely on the right-sided image where the arrow is pointing to this very high density within the submandibular gland at that site. So a good appearance for a calcification, a submandibular gland, sialadenitis, a stone within the submandibular gland with some inflammatory infectious changes. Here's another case very nicely on this sagittal reconstruction on the Bono algorithm, the image on the right, where we see the arrow pointing at all these calcifications arising from the submandibular gland going along the submandibular duct anteriorly. Here's another case. So here we have a bunch of calcifications within the parotid gland itself. And you see on the image on the left side of your screen, we have dilatation of the parotid duct. So there's a fluid collection that's tubular going back through the parotid. And on the other side, we see all these focal calcifications within the parotid. On the right parotid, we think again about where that parotid duct is going. And here we have a stone right where the parotid duct should be piercing the fascia of the buccal surface over that mandibular molar tooth. So that's a good appearance for a parotid duct stone that's occluding the parotid duct and causing inflammatory infectious changes in the parotid gland itself. So next we have temporal bones on the skull base. So I'll talk about this a little bit more on the next case. But here we have an axial T1 MR. So the image on the left side of your screen is before contrast, and the image on the right is post contrast. Now these are both fat saturated image. So again, remember that the nose, we look at the nose here, and the nose is very dark on the image on the left, and it's all bright on the image on the right. So I know that the image on the right is after contrast, and the image on the left is before contrast. And I see all this enhancement kind of in the petrous apex on the side and into the cavernous sinus, into the trigeminal cistern or Meckel's cave, and extending back to the middle ear itself. And we actually see the black ghost of the ossicles on that side, and a lot of dural enhancement extending into the interlaudatory canal, then extending along the back of the clivus. Here's another case. So anytime we think about emergency, we want to include fractures. So any of the facial bones, the skull base or the temporal bone may have fractures at this site. Anytime we have fractures of the temporal bone, we try to talk about, is this otic capsule involving or otic capsule sparing? So the otic capsule is the dense bone that's around the cochlea here and the vestibule here. So that's densest bone in the body, should be bright white. Now, when we're looking at bones, like the skull base, and I use it for all the vertebral bodies, we want a much wider window than what we were talking about before. We want something like 4,400 so that we can see these subtle osseous changes that we might differentiate on temporal bone CT studies. So these are on both sides fractures that go through the basal turn of the cochlea. So these are otic capsule involving fractures. So in terms of the patient's future M&M and how well they're going to recover, whether it involves the otic capsule or spares it is important. Here's another patient who came in with very bad neck pain. So here's a sagittal T1, nose is dark, so this is T1 before contrast. And we see a lot of soft tissue here around where the dens should be. We don't see normal anatomy. It's all very dark here on the T1 axial image before we give contrast. And here's some MR images. So again, when we do an MR, this is a slow sequence. It may take a half hour to do an MRI of the spine, for example. But we have these different images. This is a T1 before contrast. The middle image here is a T2, and the image to your right of your screen is called a stir. It's like a T2 where we made the fat dark. And you can see all that fluid anteriorly in the prevertebral soft tissues. So again, this is prevertebral edema, and we all have all these infectious inflammatory changes around the tip of the dens. So on MR, we'll see those soft tissues better, but on CT, we'll see the bones better. So here's this patient's CT, and we had two different dates here in 2017 when we were doing the study. A lot of destructive changes there around the tip of the dens, prominence of the soft tissue. We see the dens as being displaced posteriorly on the later image. And as we looked out laterally, we saw significant osseous changes from the lateral mass of C1 and the facet of C2 eroding into that inferior aspect over time. So this is a case who, it turns out, was actually IV drug abuser, and this was actually infection of the central skull base. So we had all these osseous, destructive, and inflammatory infectious changes around the tip of the dens that was destroying the bone over time. So lastly, to finish up, we have lymph nodes. Often we see big, positive, solid lymph nodes all over the place if a patient has a lymphoproliferative disorder, lymphoma, leukemia, CLL, ALL, one of those. So these are big, solid lymph nodes that are all over the place in the cervical soft tissues. If we see low density, though, we sometimes think about cancer and squamous cell carcinoma specifically. So this is a cystic mass at the angle of the mandible, and you see this axial CT on the left side of your image. It's post-contrasted. And on the right side, this is a fused PET-CT image. So we have the PET, where you see that orange is increased uptake, and the base of the tongue, that's a good appearance for squamous cell carcinoma at that site, with a cystic mass of the angle of the mandible. So that's a good appearance for a oropharyngeal squame, especially HPV, that may have big cystic or necrotic looking nodes there. Anytime we see a cystic mass of the angle of the mandible, we think about an HPV positive squame. So this is a patient who came in with a big cystic area, and we thought the same thing. We thought this is probably a squamous cell carcinoma node, and they really wanted us to stick a needle in it to see. Sometimes we want to differentiate a branchial cleft cyst, or does this patient basically not have an immune system? Are they actually really bad diabetic or something else? Then we may stick a needle in it. In this case, we put a needle in, and it came back full of pus. So that's we found out this patient, they didn't know about it, but he actually was a very bad diabetic. He basically had no immune system, so his body was not reacting to this. So in this case, we did not see a lot of inflammatory infectious changes around this fluid collection, but when we put a needle in it, it came back pus. So it was an abscess. Now we also want to differentiate that from lymph nodes in the retropharyngeal space. So here's an axial T2 weighted MR, and we see these two big rounded retropharyngeal nodes. That's where we often see that. You see on the right-sided image, that's an axial post-contrasted T1. It looks kind of like a fluid collection with surrounding enhancement. And sometimes in the pediatric world, for example, these are called retropharyngeal abscesses or necrotic lymph nodes or suppurative lymph nodes. That may be a fluid collection with surrounding enhancement. In a child, your lymph system is hyperreactive, so we may get big, impressive nodes sometimes. And anytime we see weird cystic masses, especially a young woman, we think about differentiated thyroid carcinoma. So in a young woman, if we see a big, strange-looking cystic or necrotic-looking mass that looks like it's fluid density on CT, we look very closely at the thyroid, and here's a thyroid primary tumor in this patient who turned out had differentiated thyroid carcinoma. So that's kind of a review of some infectious and inflammatory changes and what we might see on emergency studies in the head and neck imaging world. So when we think about evaluating these images as a radiologist, I'm thinking about my job. My job here is kind of like the TSA. I want to evaluate everything and think about the T, the S, and the A of emergency imaging at this site. So I want to think about, is this something that's treatable? Is there something I see, just like a TS agent, I want to be very thorough in my evaluation. Do I see an obvious source of the infection or what is the inflammatory changes. And I look for adjacent complications. Are there any surrounding changes that I may think that the referring doctor needs to know about? So that is a review of emergency head and neck imaging and some very different and varied areas as we think about the upper digestive tract, the paranasal sinuses, the skull base, the cervical soft tissues. We think about them very differently, but it's a great kind of review, and we see how CT and MRI are complementary and help us evaluate these complex areas. So that's a quick review of emergency head and neck imaging, and I thank you very much for your attention.